Hello, my name is Dr. Deep Shah. I'm a GP and clinical lead at UCLPartners. I'm going to talk about the risk stratification and prioritization part of our UCLPartners proactive care frameworks. This is part of a series of videos aimed at answering some frequently asked questions and also helping the Wave 2 sites with their implementation. So we know that routine clinical care was interrupted in primary care due to the pandemic. As a response to this, we developed a series of frameworks to help support the management of these conditions in a proactive manner. The development of these frameworks were led by a clinical team of GPs and pharmacists and were supported by patient and public insight. The four core principles of these frameworks are: it's virtual where appropriate and face-to-face where needed. We encourage mobilizing the wider clinical team and non-clinical team within primary care to help manage these patients with appropriate training. It's a step change in support for self-management for patients, and we're encouraging the use of digital innovations and remote monitoring for patients where appropriate again. So what is risk stratification? Risk stratification is the process of identifying patients and categorizing them into high, medium, and low risk, depending on clinical indicators. The long-term conditions we have reviewed are hypertension, diabetes, AF, cholesterol, asthma, and COPD. This process can be used to support patients who are at higher risk and also support the care needs of the patients which are medium and low risk. So what's the rationale behind risk stratifying these patients? Case finding patients who are high risk can identify these patients and then therefore improve their management and hopefully reduce the risk of deterioration of these patients from their long-term condition. This process also enables the GPs to manage their workload by identifying patients who need urgent review and who can safely be phased for later review. As part of this review process, we've included QOF and DES contractual requirements, and this should ensure that GP practices are adequately remunerated for the reviews they're doing. This is an example of our AF risk stratification tool. So we have provided search tools for EMIS and System 1. And once the search tools are run on your clinical system, for AF, you will have 5 categories. Priority 1 are patients who are coded as AF, but not taking anticoagulation. Priority 5 are patients who are coded as AF and taking a direct oral anticoagulation and have appropriate monitoring in place. The second priority group include patients who are taking anticoagulation and also antiplatelet concurrently. And this is just a safety check for these patients. The third and fourth priority groups are patients who are coded as AF again, and for priority 3, patients on warfarin to consider whether they can be switched to a DOAC. And the last priority group, priority 4, is patients on a DOAC who have had a renal function checked but more than 12 months ago. So the first contact, which should be with the healthcare assistant, who will gather up-to-date information, including weight, smoking, blood tests, and then run the risk scores, the CHA2DS2-VASc, Q-risk, and HAS-BLED score. They can use this opportunity to educate the patient about the condition, AF in this case, stroke risk and bleeding risk, and then also signpost to share decision-making resources. The third part of this contact, we really are keen on for healthcare assistants to discuss smoking, cessation, weight loss, diet, exercise, and alcohol. And we have included lots of resources in our pack to help the healthcare assistants with this conversation. The prescribing clinician can then review these test results, the risk scores and symptoms, and then decide on whether they need to initiate or optimize anticoagulation. And then we've included a lot of training materials for prescribing clinicians on BP management and lipid management to manage the wider cardiovascular risk for these patients as well. So the clinical criteria for each condition were agreed on by a multidisciplinary team of general practitioners, pharmacists, nurses, and specialists in that specific condition. We have resources for the safe management of these long-term conditions available on our website for healthcare assistants and also for prescribers. We had input from patients from the beginning of the design stage of these frameworks, and we're encouraging the use of the wider GP team to ensure that they can gather relevant information and emphasize education, behavior, and self-management for these conditions. We've also taken a pragmatic approach in managing patients with multimorbidity. We recognize that cardiovascular conditions in particular occur together. So diabetes often occurs with hypertension, and we've included some training on managing these patients with one consultation if possible, but also ensuring that the data gathering is done in a holistic manner that should be more efficient for the GP practice and also for the patient as well. So the frameworks include search tools to help risk stratify the patients, pathways for each condition, and then scripts and protocols to help guide healthcare assistants and others in consultations. We have training for education, self-management, and self-management support for healthcare assistants, and this includes motivation, interviewing, and health coaching as well. And we have reviewed digital and other resources to support remote self-care monitoring. So this is an opportunity to risk stratify patients with long-term conditions and manage them in a slightly different way to the past. It enables you to prioritize your patients with the greatest need and use your whole workforce, and hopefully optimize your clinical care and reduce variation. Thank you. If you need any further information, please contact primarycare@uclpartners.com and go to our website to request our search tools. Thank you.